Good morning and welcome. Thank you for joining us today. My name is Dr. Jaafer Golzar. I'm an interventional cardiologist and an endovascular specialist in Chicago. I'm also the Chief Medical Officer of Avenger. And today we're going to be talking about a very, very important subject and something that I have dedicated my life to over the past decade, and that is peripheral arterial disease and critical limb ischemia. About 10 years ago, I noticed the rampant nature of patients that are needlessly undergoing amputation and really started to treat these patients aggressively to help prevent these people from preventing amputation and to help these patients live longer and be more mobile. And so that's what we're going to talk about today, is the disease process. What is peripheral arterial disease? How does it affect people? So when we talk about peripheral arterial disease, there's multiple stages, and critical limb ischemia is the end stage of peripheral arterial disease. And when we talk about critical limb ischemia, that means that the amount of blood flow, the decreased amount of blood flow, has reached such a critical stage that there's a threat of limb loss. Initially, when we see peripheral arterial disease, these patients may be asymptomatic. You might not feel anything at all. And then eventually you can have claudication, which means you have tightness and heaviness in the legs when you walk. But once it gets to that critical level of critical limb ischemia, that means you have pain at rest or an ulceration, gangrene, and eventually limb loss. So when we talk about the classification of peripheral arterial disease and critical limb ischemia, we talk about multiple different classifications that physicians use, but usually when we talk about critical limb ischemia, we're talking about patients that have an ulceration or gangrene, and that means they're on the brink of losing their leg. Now, what are the challenges? Why are we talking about this today? What are the challenges in the treatment of critical limb ischemia? Well, the treatment needs to improve. We need to focus on limb salvage instead of amputation. Now, I'm going to throw a few numbers out at you, and these might be very, very surprising. Did you know that 25 to 33% of patients undergo major amputation as the primary treatment of critical limb ischemia? Meaning, if a patient comes into the hospital in the United States of America with an ulceration or gangrene, a third of those patients will undergo amputation. That's a surprising number to me. And 50 to 75% of these patients will have no angiogram, although we know that having an angiogram will decrease the risk of an amputation by 90%. 60 to 70% of these patients never have an attempt at revascularization. They just go on to primary amputation. And depending on where you live, depends on what type of treatment you get. So this really doesn't happen in any other disease process. So if you go in with a heart attack in California, you're going to be treated the same way as if you go into a hospital in New York and have a heart attack. Unfortunately, in peripheral arterial disease, that's not the same. Here you can see a graphic representation from American Heart Association, which shows that depending on where you live, and I'm going to focus on Chicago because that's where I live right now, depends on how much your odds ratio of actually having a revascularization. So the lighter colors mean you're much less likely to have a revascularization, and the darker colors mean you're more likely. So even in this map representation, you can see the disparity of treatment. What are the outcomes of patients with critical limb ischemia? So in this study, we're looking at the 4-year amputation rate in patients that just have rest pain. They don't even have an ulceration, just have rest pain. At 4 years, their risk of amputation is 12%. Now, what's even worse is the mortality or the risk of dying. And as a cardiologist, this is really important to us because the same things that cause the blockages in the legs are the things that cause blockages in the heart. And this is how patients die. And so a 4-year mortality in patients with critical limb ischemia with just pain, not even an ulceration, is 37%. If they have a minor ulceration, 50%. And in 4 years, if a patient has gangrene, their risk of dying is 63%. So this is not a benign disease. This is not a benign disease process. And the author of this study said, regardless of the recent advances in PAD treatment, the current outcomes remain poor, especially in critical limb ischemia. Despite the overwhelming evidence for the reduction of limb loss by revascularization, patients with critical limb ischemia still receive significantly less angiograms and revascularizations, and that's unfortunate. So what is the cost of peripheral arterial disease? So if you look at all cardiovascular hospitalizations, 40% are due to cardiovascular disease, and 57%, a majority, are due to peripheral vascular disease. If you look at all-cause hospitalizations, 10% of all hospitalizations in the United States are due to peripheral arterial disease. So how do we change the culture? How do we improve the outcomes? Well, we have to really face the current myths. And the myths are, it's too costly to change a limb, to save a limb. That's not true. And we're going to go over some of these. The patient is too old. That's not true. There's no bypass targets. Well, sometimes that's true, but now we have better therapies, endovascular therapies, that you don't have to bypass patients. You actually fix their own blood vessels. Sometimes amputation is considered as conservative therapy and intervention is considered as invasive. And this is one of my favorites that I hear over and over, and it's such a disparity for me, is that they'll eventually lose their leg anyway, so why don't you go ahead and cut it off now and get it over with? Well, as a cardiologist, if I took that same stance and I saw a patient in the emergency room with a heart attack and I said, you know what, they're overweight anyway, they're gonna die anyway, don't treat them, let them die. Do we ever do that? No, we don't. So why do we treat peripheral arterial disease in that manner? So the battle against amputation is so important because amputation is never the final answer. These patients have chronic pain, a higher rate of depression, decrease in mobility, higher rate of major complications, higher morbidity, and higher mortality. So what are we talking about when we say complications, major complications? Well, if a patient undergoes amputation, 20 to 40% of these patients will have a major complication. If we save the limb salvage, 16 to 17% will have major complication if they undergo bypass, and 1 to 10% for endovascular therapy. And what are these major complications? 10 to 30% of these patients have a wound infection. If the wound is not resolved, then they go to a higher level amputation. And in-hospital amputation revision can be as high as 20%. These patients can have blood clots, cardiac complications, infections, bleeding, renal failure, and so forth and so on. And so these are not minor, these are big, big issues that can really affect the patient. Now let's talk about mobility. So once you get an amputation, again, this is myths. These are the myths that we're trying to overcome. If you get an amputation, only 18 to 24% of these patients are routinely discharged home. If we save the limb, almost 2/3 of these patients are routinely discharged home. If we can save the limb, only 20% of these patients will ever go to a nursing home or to discharge to a nursing home. If they undergo amputation, 70% of these patients will go to some other institution, such as a nursing home or rehabilitation center. And at 2 years, If we can save the limb, 80% of these patients are walking. If they get an amputation, 60 to 80% of these patients will never walk again. So it's a myth to think that go ahead and cut off the leg and start the rehabilitation process or get them into a prosthesis, because it doesn't happen. The data shows that it doesn't happen. Now let's look at the mortality. So we're not even talking long-term mortality. I'll talk to you about that. Mortality is the risk of dying. So even perioperative mortality, so your risk of dying just from an amputation itself, a below-the-knee amputation can be as high as 10%, and above-the-knee amputation can be as high as 20%. But if you undergo limb salvage, an endovascular approach, these amputation rates, these mortality rates are much lower. For bypass surgery, 2 to 8%. From endovascular procedure, 1 to 3%. And I would say 1 to 3% for endovascular procedure is extremely high, because your main risk for mortality would be bleeding at the site of the procedure, and that is pretty uncommon. In terms of the cost effectiveness, we know from multiple studies that amputation is less cost effective than revascularization, because these patients have a higher readmission rate. They have to wear prosthesis, and the prosthesis doesn't work, and then they have to come back, and then they have higher level of amputation, and it just keeps going and going. But if you can save that limb, these patients can return to a functional lifestyle. They don't need a prosthesis. They don't need to go to a nursing home. They can go back to work. And so the cost of major amputation is $10.6 billion a year. So how do we promote more aggressive treatment of critical limb ischemia? As we mentioned before, we have to change the culture of amputation. Physician education. We have to educate physicians to say, hey guys, we have the therapies, we have the treatments now to help these patients and to prevent limb loss. We have to educate patients, because if patients go to a hospital and they're told that you're going to need an amputation and nobody's done an angiogram and nobody's tried to save that person's limb, then they're doing them a disservice. And that patient needs to look for a second opinion. And a limb salvage should be a team approach with podiatry, wound care, nurses, primary care physicians, everybody working together to help save that patient's leg. And now with improvement of endovascular technologies, we have the ability to save these patients' legs and return them to a mobile state and decrease the risk of death. There's so many new technologies on the market. We can drill, we can shave, we can cut, we can stent, we can freeze. There's so much we can do if we just have the ability to see those patients and give them an opportunity to revascularize and save the leg. And we've seen this in the trends. So there's been a significant shift in bypass surgery to an endovascular approach. Over and over again, studies have shown that physicians are moving away from doing open, high-risk surgical procedures to more minimally invasive endovascular procedures. One of the newest treatment options, and one of the most exciting ones, is lumivascular atherectomy, which is the Pantheris device. Lumivascular atherectomy allows us to visualize the plaque as we are removing it from the body. So as you can see here, this device goes inside of the body over a wire. There's a special laser inside of the device that spins and allows us to see exactly what's going on within that blood vessel. Once you identify the plaque and make sure you're in a good position, then you open up the cutter and you shave the plaque out and then pack it into the nose cone, which allows us to remove the plaque from the body. Here's an example of a patient that had poor circulation, gangrene, as you can see on his image. threatened limb loss, the risk of having a below-the-knee amputation. And as you can see, with advanced technologies and endovascular approach, we were able to open up the blockage and prevent limb loss and help him heal the ulceration very quickly once they get good wound care and restoration of blood flow. So in order to demonstrate that this is possible, in order to demonstrate that we can take patients that are on the brink of losing their legs and improve their outcomes, we had a structured approach to seeing these patients and following these patients and treating these patients with a multidisciplinary approach at our hospital. So we started an organized limb salvage program at our hospital with the goals of preventing amputation, an endovascular first approach with a multidisciplinary team, which included interventional radiologists, vascular surgeons, interventional cardiologists, nurses, podiatrists. We also wanted to demonstrate decreased length of stay in the hospital, follow the outcomes and metrics, and be a precedent for a national limb salvage center. And we did this in Chicago. And how did it work? Patient comes into the emergency department with gangrene, threatened limb loss. The order set for a limb salvage consult is immediately taken place. So what happens is the emergency room department activates it inside of the emergency room, and everything happens at that time. The wound care is notified. The endovascular physician that's going to be doing the procedure, if the patient needs a procedure, is notified. All of the labs have already been put in place, and the patient is ready to go the next day. Because usually what we see, a patient comes into the hospital, then they wait a day, then their primary care physician sees them, then he ordered an ultrasound, then 2 or 3 days later, that's when we get involved. And unfortunately, a week can go by before that patient had any type of therapy to restore the blood flow. So this paradigm was supposed to increase the efficiency and decrease the time that the patient would have to wait for revascularization. After revascularization is performed, then the hard work starts with our podiatrists, our wound care specialists, that then follow these wounds and help them heal. Then we help them with lifestyle modification, smoking cessation. And then after discharge, we followed these patients very closely. And so what we found over a year of following these patients, 125 patients that were going to lose their legs, that came into our hospital. And as you remember, one of the first slides I showed you was that national average was 33% risk of amputation if you come into the hospital with critical limb ischemia. We were able to, through a multidisciplinary approach, through an approach of working together and revascularizing these, the blood vessels that were causing the problem, we were able to drop our amputation rate to 1.58%. That's truly remarkable. We were able to help a tremendous amount of patients, set a precedent for other centers to be able to follow. And remember, not only were these patients able to go back to a normal lifestyle, but also we know that we were able to help extend their lifespan. And in over 2 years, we saw a 66% reduction in major amputation. So in conclusion, I hope I was able to impart on you my passion on patients with peripheral arterial disease, critical limb ischemia, and how important it is that we save these patients' legs, and how important it is that we treat these patients very aggressively. Because these patients have a high mortality as well as a high morbidity. And despite the advancements in treatment, these patients are still not being treated appropriately. So if you or a family member or a friend or a neighbor has poor circulation and someone has told them that they need an amputation, please seek a second opinion. We have to overcome these myths and help improve our patient care, bring them back to a normal mobility, and help prevent these patients from dying. Thank you very much for your attention.